This information presented in this course is based on reference materials that are believed reliable and consistent with standards accepted at the time of presentation. Possibility of human error and ongoing research and development in medical sciences does not allow assurance that the information contained herein is in every respect accurate or complete. The information presented during the course is intended for teaching of undergraduate and graduate students in biomedical education and is intended only for teaching. Students who successfully complete this course should check the product information sheet included in the package of any drug they plan to administer or dispense to be certain that the information presented in this course is accurate and that changes have not been made in the recommended dose or in the contraindications for administration. July 9th, 2014. Anti-anginals, or drugs to treat angina. These include the nitrates, the beta blockers, the calcium channel blockers, and ranolazine. One of the earliest medical accounts of angina can be traced back to 1768. And if you look at the date, July 21st, it's almost the anniversary of this publication by Dr. William Heberden. And what Dr. Heberden wrote was, and he was a physician that encountered patients with this disorder. And what he wrote was, there is a disorder of the breast marked with strong and peculiar symptoms, considerable for the kind of danger belonging to it, and not extremely rare, of which I do not recollect any mention among medical authors. The seat of it and sense of strangling and anxiety with which it is attended may make it not improperly be called angina pectoris. And so this is the first known report of what we now understand to be angina. And again, a few things to glean from this is that the disease is not extremely rare. Another way of saying that is it's rather common. The sense of strangling and anxiety that come along with it indicates that this is a very serious episode for the patient, and the chest pain. Okay, so this was an important contribution to the field, and is still a good summary today of the kinds of symptoms that accompany angina. The coronary arteries are key in this disease state. Usually symptoms start to occur as the coronary arteries become blocked. So if you look at this diagram of a heart, and you start in the northwest corner, you'll see a healthy coronary artery. No occlusion, blood is able to flow, not a problem. If you go a little bit further down that artery, in this particular patient, the coronary artery is narrowed by atherosclerosis. If you go to the bottom right, well, I should say the top right, you see an intensive plaque buildup, hinders blood flow to the heart, causing angina. And so angina can occur when the blood vessel is severely occluded, but blood still may be able to flow through, but under different conditions, there may be pain associated with it if, for example, the oxygen demand is not meeting the need of the heart. And if you look in the lower right, here's a very bad situation where that atherosclerotic plaque, which was allowing just a little bit of blood through, is now blocked by, let's say, something like a blood clot. Depicted here, completely blocked, blocking blood flow to the heart, depriving the heart of oxygen, causing a heart attack, and you could see in that grayish, blackish shade at the bottom of the heart, you see ischemic death of the heart. And so this is something we'd like to avoid to the extent that we can. So really, in angina, we have changes in coronary arteries, and it's when those changes become very severe or when the lumen of the arteries become blocked that we can get heart attacks. It's as if the heart is gasping for air because it's not getting enough oxygen from hemoglobin because not enough blood is moving through that vessel. This figure shows the typical progression of coronary atherosclerosis. If you look at the upper left, you see a cross-section of the normal blood vessel, the normal artery. The walls of the artery are healthy, the lumen of the artery is open, and blood can flow without a problem. As you look to the presence of a fatty streak, you start to see a narrowing of the lumen. It's not likely to cause symptoms. The tests are going to look normal because the amount of blood flowing is still enough to supply the tissue. Even as we get a plaque and an increasing plaque, the lumen is still large enough to allow adequate blood supply. However, as that lumen starts to get occluded, as the blood vessel wall starts to remodel itself, as we heard about in the pathology portion of the class, all of a sudden now our non-invasive diagnostic tests are showing abnormality. We're seeing a patient who's feeling chest pain when they increase the oxygen demand on the heart, such as when they go from sitting to walking very quickly, or when they enter a situation where they have to lift lots of things, and the oxygen demand for the heart can't be met. Now, a worser scenario is depicted for you here on the right, where you get a fissure of the plaque. You can get a blood clot formation, or severe blockage of the lumen of the vessel, causing a condition called unstable angina, and hopefully, excuse me, not a myocardial infarction. So in acute coronary syndromes, the vulnerable plaque is a more important factor than the fact that there is a plaque. It's when the plaque breaks, allows a blood clot to form, that we start to really be concerned. And so vulnerable plaque within the vessel may not be obstructive and may remain clinically silent until it causes rupture and associated consequences. While there are multiple types of angina, the three most common types are stable, unstable, or Prinzmetal's. And so I'd like to briefly talk about the three types right now. Stable angina is characteristically caused by an obstruction in one or more coronary arteries. And so while the restricted blood flow is adequate for oxygenation of the unstressed heart, it is insufficient for the increased demand posed by such events such as exercise or emotional stress or exposure to cold, for example. Okay, so it's able to handle the unstressed situation, but once the demand goes up, it's unable to provide the demand. In unstable angina, we have a situation where new onset angina presents as severe and frequent attacks, or there's a change in patterns, there's an increase in frequency or intensity or duration of previously stable angina. Okay, so unstable angina is one component of a group of clinical symptoms called acute coronary syndromes. ACS involves ST segment elevation myocardial infarction, and non-ST segment elevation myocardial infarction. And this is referring to patterns on an EKG during a myocardial infarction. Some infarctions are or involve ST segment elevation, while others do not. In most patients, acute coronary syndrome results from disruption of an atherosclerotic plaque. Okay, so there was a stable plaque usually, and here we've disrupted it, causing platelet adhesion and aggregation, thrombus formation, vasoconstriction. And this disruption causes partial occlusion of one or more coronary arteries, restricting blood flow to the extent that it fails to meet the oxygenation demands of even the unstressed heart. And so people with unstable angina are at increased risk for myocardial infarction or sudden death. Their risk is 10 to 20%. But appropriate therapy significantly reduces this risk down to 5 to 7%. Prinzmetal's angina is a rare form of angina caused by coronary vasospasm and reduces coronary artery blood flow. Typically here you'll see a transient ST segment elevation, but the problem is there's a risk of progression to myocardial infarction, and that prolonged vasospasms may lead to ventricular arrhythmias, heart block, or death. Okay, so this is generally a rare form of angina. The patient might complain here of chest pain while they're resting or doing their daily activities, or in some cases if they've exerted themselves. Okay, so here the big thing to worry about is that the patient may be at rest and still have an angina attack. And so luckily this is rare, but this does occur. And in fact there are other. And so as I was ending that last slide, I got cut off, and what I wanted to tell you is there's other types of angina as well. But the three major types that are most commonly encountered have been discussed: stable, unstable, and Prinzmetal's. Now, the majority of cardiac disease in Western industrial world stems from myocardial ischemia. Myocardial ischemia arises when the blood supply to a region of heart muscle is inadequate to meet oxygen demand. The major ischemic heart diseases, IHDs, are stable or unstable angina and myocardial infarction. And then there are conditions secondary to ischemic heart disease which can be initiated due to ischemic heart disease, things like various arrhythmias or heart failure, for example. Now, angina pectoris is a clinical manifestation of myocardial ischemia, and its presentation may vary. However, the classical symptoms are substernal pressure or pain brought on by exertion or stress, and that this pain will abate soon after cessation of the precipitating factor. Angina pectoris is known as a clinical syndrome, possibly known since antiquity. But the term angina pectoris, as we've seen a little earlier today, was first put forth by Dr. Heberden in London in 1772. Coronary artery atherosclerosis almost always occurs in large epicardial vessels, those right around the heart. It is most common in main branches, usually near ostia. However, more diffuse involvement is possible. Unless they are large, atheromas do not significantly reduce coronary blood flow. And this is probably due to compensation via coronary vasodilatory reserve of an arteriolar bed. However, as the lesion reduces the luminal diameter by more than 50%, vasodilatory reserve is exhausted at ever lower levels of cardiac oxygen demand. And hence, there seems to be an exertional threshold for ischemia decreases. At nearly total occlusion, ischemia can occur at very low exertional threshold. Although post-stenotic collateral circulation may prevent resting ischemia. Large atheromas can become sites of thrombi or emboldy. Lesions in large proximal artery will comprise more myocardium than in smaller distal branches. Thus, left main disease is especially serious. And then 1, 2, or 3 coronary arteries may be involved. The more vessels involved, the higher the risk. So the question is, what to do when the coronary artery looks more like what's on the right in this picture than what's on the left. Obviously in dyslipidemias, we talked about how these plaques form and how we'd like to slow them down or stop them altogether. But once they're there and the vessel is occluded and the symptoms are occurring, what kinds of drugs are there and which will be effective? And this will be the topic of today. We're going to talk about the drugs in a moment. As a diagram of the anatomy of the coronary arteries, basically on this slide, what you see is a drawing of the heart. And the dark bold lines indicate, for example, the right coronary artery, the left main coronary artery, the circumflex artery, lots of branching of the artery, the left anterior descending artery, the posterior left ventricular branch, and so on. And so what you basically see here is that these arteries are mainly responsible for perfusing the heart. So blockage of them will cause devastating problems to the heart. And so the idea here is to prevent those lumens of the blood vessels from being completely occluded. Oxygen demand of the heart muscle is intricately important when it comes to angina, because in the case of an occluded blood vessel, whether it's occluded 50% or 70%, the amount of blood that's going to flow through those coronary arteries is going to be less than otherwise would be. And so as that blood primary function is to carry oxygen so that the cells of the heart can use it for energy, there'll be less oxygen per unit time in a coronary artery that's occluded compared to one that is not occluded. And so there's really 3 factors that are going to affect myocardial oxygen demand. These are the heart rate, the contractility of the myocardium. Is it beating hard, which is going to require more energy? Is it beating less intensely, which is going to require less energy? And systolic wall tension. And that in turn is largely governed by ventricular volume and intraventricular pressure. Remember, systolic wall tension is, what's the pressure on the walls of the heart when the heart is relaxed? When the heart is contracting. And diastolic would be when the heart is relaxed. So an increase in any of these factors, in the heart rate, in the contractility, and the systolic wall tension, will cause increased myocardial oxygen demand. So let me give you a concrete example. Let's say during exercise, the heart rate, the contractility, and the blood pressure all increase, and that will increase the need for oxygen. The following also elevate myocardial oxygen demand via an increase in one or more of the above determinants: hypertension, tachycardia, left ventricular outflow obstruction like an aortic stenosis, hypermetabolism such as thyrotoxicosis, anemias where there's less oxygen carrying capacity of the blood, or severe emotional stress. So if we kind of turn those words into a picture, what you can see here in the bottom left, myocardial oxygen demand being influenced by heart rate, myocardial contractility, and systolic wall tension, which systolic wall tension is going to be affected by the intraventricular pressure and the ventricular volume. So we can think of the heart as having an oxygen demand because of the work it does. And we have rate work and stretch work in addition to contractility. So angina pectoris or angina pectoris is a consequence of myocardial oxygen demand exceeding myocardial oxygen supply. So when the demand exceeds the supply, the balance tips to the left, and we get ischemia. And the reason for this is that the supply can't give enough because of narrowed vessels, and so the demand is high, it's not being met, and so the balance tips to the left, and we result in ischemia. So the next slide is going to show you, in a cartoon sketch, the fluctuations in cardiac oxygen demand and supply when the coronary arteries are normal. And in that case, the supply is always able to meet the demand due to vasodilatory capacity of coronary circulation, and that's under autoregulation. Now, fluctuations in oxygen demand shown in the next slide are due to exertion, tachycardia, or emotional stress. And other factors increasing demand include hypertension, anemia, hypermetabolic states, or left ventricular outflow obstructions such as aortic valve stenosis. And so with the possible exception of severe thyrotoxicosis and valvular disease, the above conditions alone are not likely going to cause ischemia. And this is because the normal flow reserve is still usually able to meet the very elevated demand. However, they may cause or lower the threshold for ischemia if coronary artery disease is also present. They meaning situations such as hypertension or anemia. Okay, so the heart, the coronary arteries have some what we can call reserve, but as they continue to narrow, there'll be less and less oxygen that can come to the heart. And so, as I mentioned, the words to this slide were on the previous slide. If you were to look at the myocardial oxygen demand, the solid black line over a day's worth of time. So 7 a.m. comes, the patient wakes up, and by 10 o'clock they're at work, they're working hard, they may have tachycardia, then they'll take a break at lunch, and their heart rate might drop slightly, and then they'll start working again, and they might have a stressful meeting, and then they might go work out after, and then they'll come home and eat dinner and go to bed. And so if you watch that solid black line, that would be the typical oxygen demand for that person for that day. And in a situation where you don't have angina, the supply mirrors the demand, and wherever you look, there's usually enough supply to meet that demand. Okay, so if we look at work, right, we have a certain supply, but we offer a certain demand, but that demand can be met. And so other factors increasing myocardial oxygen demand include hypertension, anemia, increased metabolism, or left ventricular outflow obstructions. Vasodilatation, secondary to carbon dioxide accumulation, provides oxygen and nutrients to tissues in non-diseased blood vessels. So now let's look at the myocardial oxygen balance over 24 hours in a patient that has coronary artery obstruction and spasm. So again, myocardial oxygen demand is the solid black line, and myocardial oxygen supply is the dashed line. And as you can see, here in the diseased patient, we start to have areas where we can't meet the demand. So for example, if you look at emotional stress around 5 p.m., patient is very stressed out, there's no oxygen that's being able to meet the demand. Right? Or even a little bit later, that same day, a patient goes to exercise, but there's not enough oxygen to meet the demand. Okay, and so those areas where you see arrows pointing to says myocardial ischemia, those are times where the heart can suffer and be injured. And so there are other factors that decrease myocardial oxygen supply. Okay, they include things like hypotension and platelet aggregates, and if a patient has congenital abnormality. Now, lipid occlusion of vessels does not permit vasodilatation, fixed vascular resistance, and the resulting imbalance between supply and demand results in myocardial ischemia, hatched lines, and chest pain. Okay, so normally during those times, for example, of emotional stress or exercise, the blood vessel could dilate and bring in oxygen to override the problem. Okay, so those are important aspects of this patient with coronary artery obstruction, that their demand might be a certain demand, but their body may only be able to reach a certain threshold. Okay, it might only be able to maintain so much. Typical characteristics of angina pectoris: sensation of pain, pressure, burning, or tightness in the chest. Located near the sternum, the left or right shoulder or arm, the jaw, the posterior neck, or the back, or the abdomen, may radiate to the left or right arm or shoulder jaw. May occur with dyspnea or feelings of anxiety or dread. It might be related to exercise or to cold or to meals or to emotion or to coitus. And generally the duration of the pain can be anywhere from 30 seconds to 20 to 30 minutes. And it can be relieved by nitroglycerin in anywhere from 1 to 5 minutes when administered sublingual. The subtypes of angina pectoris and their common clinical profiles, and the types of drugs that they respond to. So if we look, for example, at stable angina, it can occur with exercise, it can occur with emotion, some kind of strong emotion or stress, but it's not going to occur with rest. Okay, this is usually going to occur on exertion. On the ECG, the ST segment is depressed, and stable angina responds to drugs like nitrates or beta blockers or calcium channel blockers. So these are all used to treat stable. In unstable angina, you can have it occurring with exercise or with emotional stress or even at rest. The ST segment may be depressed or elevated, and again, all three of these drug classes have been used to treat unstable. With variant angina or Prinzmetal's angina, infrequently will you see it with exercise or with emotional stress, but you may see it at rest, which is, maybe while you're sleeping or just taking a break from the everyday routine. But this is obviously pretty troubling because it's happening at rest. The ST segment is usually elevated. There's response of this particular angina to nitrates and to calcium channel blockers, but in Prinzmetal's angina or variant angina, the beta blockers are generally less utilized and not as effective. And so we'll explain why this is as we move forward. So characteristics of stable angina, the most common subtype, it can be induced by relatively consistent exertion level. Angina attacks are more likely in the morning or after a large meal, with cold or wind or during strong emotion. And the ECG during the stress test generally reveals ST depression as being common. Characteristics of unstable angina. A recent change in severity or frequency of attacks or loss of response to usual medications may occur during rest or sleep as well as with exertion. And the ECG during ischemia, you see ST depression the most common, but almost 1/4 of the patients will have ST elevation, and it's not clear why, but maybe due to vasospastic component. The characteristics of variant angina or Prinzmetal's angina occurs mainly at rest with good exercise tolerance. The main cause is probably coronary vasospasm, although atherosclerosis may be present. So this might just be a spasming coronary artery, not necessarily blocked. The ECG during the attack, ST elevations are most common, but ST depressions are possible and have been observed in some patients. The exercise stress test is usually negative, and the prognosis is generally good. Tools for diagnosis of coronary heart disease. Well, in the initial evaluation, the patient history, their physical exam, including a resting ECG, a chest X-ray, perhaps fluoroscopy, and lab studies will be carried out. Additional testing such as stress tests or radionuclide studies or echocardiographs or coronary arteriographs or LV angiographs may be required as well. Major prognostic determinants in coronary heart disease include the degree of left ventricular dysfunction, the extent of coronary artery disease, the severity of the ischemia, and whether or not there have been any recent ischemic events, such as myocardial infarction. The regulation of smooth muscle contraction and relaxation is shown here in this figure. As we can see, drugs may relax vascular smooth muscle in several ways. One way is by increasing cyclic GMP, as you can see here on the bottom right. Doing so facilitates the dephosphorylation of myosin light chains and prevents the interaction of myosin with actin. Nitric oxide, for example, is an effective activator of soluble guanylyl cyclase and acts mainly through this mechanism. Important molecular donors of nitric oxide include nitroprusside and the organic nitrates used in angina. Decrease intracellular calcium, the calcium channel blockers. These predictably cause vasodilation because they reduce intracellular calcium which is a major modulator of the activation of myosin light chain kinase. Beta blockers and calcium channel blockers also reduce calcium influx in cardiac muscle fibers and thereby reduce the rate, contractility, and oxygen requirements of the heart under most circumstances. Well, another way to regulate smooth muscle contraction in the blood vessel is to stabilize or prevent depolarization of the vascular smooth muscle cell membrane. Recall that the membrane potential of excitable cells is stabilized near the resting potential by increasing potassium permeability. Potassium channel openers such as minoxidil, for example, increase the permeability of potassium channels, probably ATP-dependent potassium channels. Certain newer agents under investigation for use in angina may in part act by such a mechanism. Lastly, increasing cyclic AMP in vascular smooth muscle cells. As we see here in the figure, an increase in cyclic AMP increases the rate of inactivation of myosin light chain kinase, the enzyme that's responsible for triggering the interaction of actin with myosin in these cells. This appears to be the mechanism of vasodilation caused by beta-2 agonists, drugs that are not used in angina. And the reason why is that they may cause too much cardiac stimulation. Neither here nor there, this diagram clearly illustrates a few of the mechanisms involved in contraction and relaxation. On the one hand, on the left, we see calcium pathway stimulating the calcium calmodulin complex in the myosin light chain kinase to make a phosphorylated myosin, which then went on phosphorylated myosin light chain kinase, which then went on to interact with the myosin light chains to phosphorylate them, allowing them to interact with actin and contract the cell. Okay, so when you look at this slide, be careful to understand what's going on. What is calcium normally doing? What does blocking calcium result in? What is cyclic GMP normally doing? What is ATP normally doing? So here we have a more complex drawing where we include the endothelium, the interstitium, and the vascular smooth muscle cell. And this slide very importantly illustrates the mechanism of action of nitrates, nitrites, and other substances that increase the concentration of nitric oxide in vascular smooth muscle cells. The steps leading to relaxation are shown here in the green arrows. And as you can see, nitric oxide will come into the cell from the endothelium, will come into the vascular smooth muscle cell from the endothelium through diffusion, and will stimulate guanylyl cyclase, and guanylyl cyclase will stimulate cyclic GMP. In the meantime, the nitrates and the nitrites are similar to nitric oxide, and sildenafil is in some ways similar, but in other ways different, because it acts as an inhibitor of phosphodiesterase. By inhibiting phosphodiesterase, cyclic GMP levels stay high. And so the mechanism of action of nitrates, nitrites, and other substances that increase the concentration of nitric oxide in vascular smooth muscle cells is shown here